Welcome, everyone, to the People's Health Briefing, a vibrant component of our Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health, reporting for the week of April 15th, 2024. You might notice I said Roots Community Health as opposed to Roots Community Health Center, and that is because we have reached an exciting moment in our journey. With over 15 years of service and growth, we're ready to unveil our next chapter, acknowledging that we are much more than a healthcare provider and that health happens beyond clinics and health centers. Our rebranding initiative reflects our commitment to transforming community health outcomes inside and outside of the exam room. It goes beyond just a name change to embody our integrated approach, combining clinical services, outreach, social enterprises, and community health education to foster holistic well-being. I want to extend my deepest gratitude to the incredible team behind this transformation and invite everyone to join us as we continue to challenge the status quo, champion health equity, and uplift communities that have been marginalized for far too long. As health professionals rooted in Oakland, serving some of the most vulnerable populations in the Bay Area, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. The goal of the People's Health Briefing is to equip you with the best knowledge and insights to keep you, your loved ones, and your community as safe as possible. This week, after an update on COVID, flu, H5N1, and measles, we will hear an MPox overview from Root's very own Dr. Kenji Taylor. Starting off with our so-called respiratory virus season, which in the United States is roughly October through now. And I say so-called respiratory season because we know that there are different types of respiratory viruses that circulate all year round. We also know that SARS-CoV-2 tends to have multiple peaks throughout the year. But generally, winter season is when we see the most circulation of the most problematic respiratory viruses, flu, RSV, SARS-CoV-2, along with some others. So we can see first that wastewater concentrations of SARS-CoV-2 are coming down. They're certainly not zero. It actually has not gotten down to zero since we started monitoring it, but heading down nonetheless. Upper right corner, you can see the influenza A in yellow, influenza B in green, also both heading down. Hopefully the season will be behind us soon. Likewise, RSV, lower left there, heading down. And on the lower right, we can see that even though we do still have flu hospitalizations in the blue, COVID hospitalizations a bit more in the orange, they are slowly heading down as well. When we look across the country at influenza activity, we can see that it is quite variable with high circulation in North Dakota and to a lesser extent in New Mexico, Nebraska, New York City, New Jersey, Massachusetts. And we can see that it is minimal in a number of states, including Texas, Arizona, and Utah. And those are the greens. And over the next month, we would hope to see most of the country in shades of green, but we will keep watching. And here we have COVID hospitalizations on the left, showing that the week ending April 6th, we had just over 7,000 hospitalizations. So that is coming down nicely. Actually, the 13th week in a row that we're seeing declining hospitalizations for with COVID. And taking a look at deaths on the right, the week ending March 16th was the 9th week that we were seeing declining deaths. And we know that this number lags behind a bit, and it may also increase as more data comes in. But at 961 deaths for the week ending March 16th, this would mark the first week in which we've had under 1,000 deaths in the US from COVID since last August 2023. So we've had over 1,000 deaths every single week since then. So glad to see it coming down, and with hospitalizations having come down since that time, we would expect deaths to continue coming down for at least that long. And of course, we'll just have to keep an eye out to see when cases start to come back up. This could be summer, this could be early summer, could be late summer, could be early fall. And I think it's most likely that we will see at least one more COVID wave before next winter's wave. But you never know. SARS-CoV-2 has been full of surprises this entire time, but we would certainly be wise to be prepared for a summer surge. Of course, we have no idea what month or how large, but it certainly has been the case in prior years. And even though, it's good to see this number coming down, 1,000 deaths a week is still too many. And we know that many of these could be prevented if we would decrease transmission, if those who are vulnerable would get an updated vaccine, and if those who are at risk of a poor outcome would get timely treatment. So these should be our goals: reducing transmission and appropriate access to vaccination and treatment. Now, taking a look at variants, fortunately, we are still seeing primarily the J1 variant, so no news is good news here. We certainly hope it stays this way. We've not heard confirmation about the schedule for an updated booster, but if they stick with what was discussed last year, what was decided last year, we would expect a new formulation of SARS-CoV-2 vaccines in the fall as they try to time it with the fall vaccination campaign. So hopefully we end up with a booster that's well matched to the variant that's circulating. We've been kind of chasing behind and pretty much a step behind this entire time, but maybe things have slowed down to the extent that we get a good match, and time will tell. So in the meantime, let's strive to maintain our best practices for preventing the spread of all respiratory infections, but especially to avoid catching and spreading COVID, so we can prevent these poor outcomes, including long COVID and post-COVID impacts. Flu, COVID, and now RSV are the respiratory viruses that we have vaccines for. We're at the tail end of flu and RSV season now, but worth making sure that you stay up to date on those. Remember that an additional COVID vaccine is now recommended for those 65 and up, in addition to those who are immunocompromised. For everyone else, the recommendation we seem to be settling into is going to be an annual vaccine, much like the flu. Try to gather outside as much as possible. If you're going to gather indoors, wear a high quality filtration mask like an N95 or KN95, and do what you can to improve ventilation and filtration in your indoor spaces, which you can monitor using a CO2 monitor to get a sense of your indoor ventilation. And let's strategically test and isolate to avoid spreading it to others. If you do test positive, please isolate until you are negative, because enough virus to detect is enough to infect. And we know that we can prevent spread even within households by taking preventative measures. Because remember that catching COVID once and doing fine is not a guarantee about the next time, and every infection is a new opportunity, perhaps even a compounded opportunity for long COVID and post-COVID impacts. Please also don't push yourself. Allow yourself the time you need to fully recover. If you're someone who should be treated, if you get COVID, you should know that now. Don't wait to see how you do. That is not how that works. Here are the approved treatments for those at higher risk of a bad outcome. It's going to be Paxlovid as first line for the majority of folks, and the sooner you start it, the better. Lastly, we are waiting to hear about access to Pemgarda, the prevention injections for those with immunocompromise. It has been approved, not clear yet where we're going to be able to find it, so we will keep you posted as we learn more. And to report briefly on H5N1, I covered this in a lot of detail 2 weeks ago, so the link for that briefing is in the post in case you want more details. This is kind of a summary of the current situation. We know that H5N1 or avian flu impacts wild birds, and this has now been detected in 50 states, but we're seeing it impacting poultry as well, with 48 states reporting outbreaks affecting over 85 million poultry. And what is concerning and what prompted us to discuss it in the briefing 2 weeks ago was a case in a human in Texas where it was apparently transmitted from a cow. And this is an individual who works closely with cows, but nonetheless, this is the first time that we've seen this happen, spread from a cow to a human. This is actually the second U.S. case in a human, but the first one seemed to have come from an infected bird, which is what we've also seen worldwide in prior cases. But on April 1st, this appears to be the first report in the United States that we have of transmission from a mammal to a human. So H5N1 has been detected in cows, and it is now spread to at least one human so far, and this appears to be the first report that we have of transmission from mammal to human. So that in and of itself is concerning. Unfortunately, I don't have a whole lot to add this week because we still aren't getting a whole lot of detail about the cows. We know that H5N1 has shown up in livestock in at least 8 states just this month, the month of April. And not just in Texas, but Michigan, New Mexico, South Dakota, a few others. If you're interested, the USDA has a map, which I have linked in the post. But there's not a ton of information about exactly how it's spreading. Mainly what we've seen is mostly theories. So it is an evolving situation. For the average individual right now, the main thing would be to not consume raw milk products or raw or undercooked meat. If you work closely with livestock or animals, there are specific guidelines from your respective regulatory and oversight bodies, and we will report more as we have it. And now briefly on measles. As of April 11th, there have been a total of 121 measles cases reported in the United States, and this is in 18 different jurisdictions. The link is in the post if you'd like to read more details. But by comparison, in all of 2023, there were only 58 cases. But here we are in mid-April 2024, and we are already at 121 cases. Now, this is not unheard of. We actually had over 1,000 cases in 2019. We had over 600 cases in 2014. So this can happen from time to time. But the reason why we're a bit concerned this time is because this seems to be correlating with dropping off of childhood vaccinations in certain regions and in more regions than perhaps we've seen it before. The other concerning thing is that 56% of those with measles this year so far have been hospitalized. Most of the cases have been in children under 5, and within that age group, 65% of them have had to be hospitalized. Now, as a reminder, children are not eligible for the first dose of MMR until they're a year old, and they don't get their second dose until they're 4 to 6 years old. So typically those under 5 are only partially vaccinated. So it stands to reason that the majority of the cases so far have been in children under 5, and it is concerning that 65% of them have had to be hospitalized. So far overall with the cases in 2024, 82% of individuals who got measles were unvaccinated. 13% had one dose. So nothing is 100%. MMR vaccine is no exception. It's overall quite effective, but there are some people who may not mount a good response, and we don't always know why that is. There are also some people who cannot get the MMR vaccine, like people who are severely immunocompromised. So all of these individuals, those who, for whatever reason, don't mount a good response, those who are under 1, those who are only partially vaccinated, those who can't get MMR, all of these groups of individuals are vulnerable to getting measles if it starts spreading around. So when more than 95% of people in the community are vaccinated, then we have reached a level of essentially herd immunity or population immunity. So this is really the threshold we want to maintain. 95% or more people being vaccinated within a community. Unfortunately, we are seeing that vaccination among kindergartners in the United States has decreased a couple of percentage points across the board in the US, so dropping from above 95% now closer to 93%. And in some areas, it's decreased much more than others. There are definitely some pockets of lower vaccination and higher vaccination across the country. Here we can see MMR coverage for kindergartners for the 2022-23 school year. We can see very good coverage in the states in light blue, places like California, New York, Maine, Virginia, Mississippi, Tennessee. The states we are particularly concerned about are those in the darker orange, like Idaho, Colorado, Minnesota. Idaho's coverage is quite concerningly low at just 81.3%. So generally speaking, everything will be fine until it isn't. Someone with measles, for example, visits one of these areas, or someone who has not been vaccinated travels abroad to other areas that are also experiencing outbreaks, like many places in Europe right now, and then they bring it back to some of these areas with low vaccination coverage, and it can spread like wildfire through an unprotected population. And this is what we would like to avoid. So for the most part, if you are fully vaccinated, you should not have much to worry about. Please make sure you're fully vaccinated. Make sure the children in your life are fully vaccinated. Because if you're not, and then you go anywhere near someone who's contagious, even going in the room after they've left, there is about a 90% chance that you will get sick with the measles, which can be life-threatening. Also, if you will be traveling internationally, no matter where you're going, please make sure you're vaccinated. If you're traveling with an infant between 6 months and 1 year of age, they likely will be recommended to get started early on that MMR series to protect them on the trip. So please check with your child's pediatrician on that. And now I want to switch gears a little bit to get us to our main topic today, which is MPox and HIV. And this week is actually STI Awareness Week. STI stands for sexually transmitted infection. And unfortunately, we have too many sexually transmitted infections that are on the rise in the United States. In 2022, that's the last time period where we have the full surveillance report, there were over 2.5 million cases of chlamydia, gonorrhea, and syphilis reported in the US. We are also seeing a tragic increase in congenital syphilis, which is babies being born with syphilis, which is life-threatening, life-altering if they survive. Yet we know that much of this is preventable and treatable, but of course you have to get tested and diagnosed to get treated. Now, before we hear from Dr. Kenji on specifics of MPox and HIV, I wanted to point out where we are nationwide with MPox. In 22-23, we had over 32,000 cases of MPox in the United States, with the highest numbers being seen in California, New York, Texas, and Florida. There were 58 deaths, and Dr. Kenji will talk a little bit more about who is dying with MPox. Remember, MPox is the new terminology that WHO is calling the disease caused by the monkeypox virus. And generally that's because even though in past years, the vast majority of cases were spread in rural areas to a human who was in close contact with a monkey, that is no longer the case. This new variety, or clade 2B, is what caused the global outbreak beginning in 2022. Where we have seen a sustained human-to-human transmission. So still the monkeypox virus causes the disease monkeypox or MPox. And now let's hear from Dr. Kenji.
Hello, everyone. My name is Dr. Kenji. I am a primary care provider at Roots, as well as one of the HIV medical directors for our program. Thanks so much for the time to talk with you all today. What I'm going to be talking about today is understanding monkeypox and its relevance to HIV. Specifically, three main messages about treatment, vaccination, and prevention. So what exactly is monkeypox? Monkeypox is a virus that is similar to smallpox, but less severe, generally speaking. It was first identified in monkeys, but rodents are actually the main carriers of this disease. Monkeypox spreads through intimate contact with someone who has monkeypox. So that may be skin-to-skin contact, that may be sex, that may be kissing, that may even be sharing linens. Symptoms are, for most people, are going to be limited and mild, but for some people may actually be life-threatening. So let's dive into a little bit of what monkeypox symptoms actually look like. So there's important three phases here to infection. The first one that you'll see here on the right-hand side is the incubation period. The second period is the prodrome period. And the second period is the actual outbreak of the rash, pictured here on the left-hand side of the screen. The incubation period is the actual initial infection with the monkeypox virus. It may last 1 to 2 weeks. You may have no symptoms at all, and you may actually still be contagious during this period. The second period is the prodrome period. This is where patients oftentimes present to our clinic because they may have these symptoms that are lasting for a few days. They're sort of like having the flu. So you get body aches and chills, fevers, that sort of thing. And you may certainly be contagious as well during this period. And then the third period is the rash. And this is most definitely when folks are coming in to see their doctors or their providers about it, because this is a characteristic rash that breaks out. that may last up to 2 weeks. You get these sort of vesicles or these little blister looking things all throughout your body. And they can look different on different types of skin and depending on where they are and depending on what stage of the rash they actually are in. Once the rash scabs over and you get a new layer of skin on top of that, that's where you are no longer contagious. So I want to talk a little bit about monkeypox specifically in Alameda County. And when this outbreak happened back in May of 2022, you'll see here on this graph, the x-axis shows time, so the date and the year. And the y-axis, the vertical axis, shows the number of cases or probable monkeypox cases that we had in Alameda County, specifically to our county. So you'll see this spike in this blue boxes here shows you had a rapid rise of monkeypox cases back in May to June of 2022. And then you had a rapid fall in those cases, but a continued level of cases even as far back as the end of last year and up to this year. What I really want to stress home and why we're really talking about this today for our community is that the Oakland cases actually account for 60% of the monkeypox cases in Alameda County. So very much so, a lot of the cases are happening right here in Oakland and important for us to know about. So I mentioned at the very beginning, monkeypox as well as HIV. How are these two things connected? They're connected in that folks with HIV are at much higher risk for death, serious illness, and transmission. We know that 94% of monkeypox related deaths were actually immunocompromised individuals. So folks with HIV who were not on treatment, 94% of them were accounted for those cases of MPox related deaths. And secondly, 40% of the MPox infections alone have been among people with HIV in California. So I really want the community to know about that, but particularly as I care for, and so we care for patients living with HIV, them to know about the dangers of monkeypox if it is left untreated or undiagnosed in folks with HIV. So the last part I'm going to talk about here are really kind of summarizing and really hitting home these 3 points that are really, really important about monkeypox: treatment, vaccination, and prevention. So just to summarize where we are, monkeypox is a virus. It's spread by intimate human contact that has made a resurgence in the United States, and particularly here in Alameda County, and particularly here in Oakland. Disease, the monkeypox disease or infection, while mild for most people, can be quite severe in those living with HIV and people who have a weakened immune system. So what are the 3 ways that we can really, again, prevent those things from happening? Treatment, vaccination, and prevention. Treatment, vaccination, and prevention. I'm going to talk about each of those 3 things in a little bit more detail here. So treatment, with a medication called TPOXX, we call it TPOXX. This is treatment for those who either have severe infection, so maybe they have a rash that's all over their body, they have really severe symptoms, they have a really bad case of the monkeypox for whatever reason it might be, or for those who are high risk. So specifically, typically it's people who have immunocompromised. We talked a little bit about one specific group, which is folks who have HIV who may not have well-controlled HIV that has compromised or weakened their immune system. And this is really usually a conversation when you come into your doctor, when you come into your provider with your concerns, you are diagnosed with monkeypox. That's a conversation to have with your provider at that time to say, hey, do I need treatment? Which really stresses the importance of getting in for treatment if you're concerned about it. So what is TPOXX, this medication? It's an antiviral drug that was developed initially to treat smallpox that basically keeps the virus in check. It keeps it from replicating, it keeps it from going all over your body, and it keeps the virus from causing severe infection. And we do know that it is effective in doing this. And what's great about it is that it's available in Alameda County, and it's certainly something you could talk to about with your Roots provider if you have those concerns. Because really you're going to be talking about, is treatment right for me? And asking those questions that you need to feel comfortable getting the treatment if that's what it is that you need. So that's treatment in a nutshell. That's pillar number 1. So pillar number 2, or point number 2, is really about vaccinations and the Jynneos vaccination. So this particular vaccine is very effective. And we know this is actually one of the best ways to prevent severe infection with monkeypox, as well as prevent the spread of it. So it's a 2-dose vaccine series, which means you get 1 dose first, and then you get a second dose later. That first dose, we know the vaccine efficacy is about 36 to 75%, even just with that first dose. So certainly getting that first dose is the important first step. But what we do know is that second dose is also really, really important. So if you've gotten 1 dose, that's awesome. Come back in and get your second dose. And that second dose we know is 66 to 86% effective for those 2 doses. So everyone always asks, there's many different types of vaccines out there. This particular vaccine is actually made from a weakened, inactivated smallpox and monkeypox virus. So what does that mean? It is actually, they take those viruses, they strip away all the mechanisms that make them effective at actually infecting people, and they give you a little bit of a dose of that so that your immune system builds a response to it. But you cannot get sick from this vaccine. You cannot actually get the virus itself, and it is a completely inactivated, weakened form of the virus that makes it so effective. The last great point of news about the MPox vaccine is that it's available at Roots Community Health, and it's something that you can talk about with any of your providers here. If you ever have any questions, certainly you can find information here for you to get vaccinated as a part of preventing the spread of monkeypox and also preventing severe disease from monkeypox. So the last part, the last or third pillar that I'll talk about with monkeypox is the prevention piece. Now, I'm going to double down on my initial point about that vaccination piece, just how important it is, because getting vaccinated not only prevents spread, but it also helps prevent severe illness. And so getting vaccinated is a very, very important part of prevention. The second kind of piece about prevention is lowering your risk of monkeypox during sex or social gatherings. There's many ways that you can do that. And certainly if you have questions about that, there's information available online. And seeing your primary care provider or coming to a Roots provider is a great way to be able to do that. And the third thing is avoiding skin-to-skin contact with someone who has a rash. So we talked about those symptoms, those 3 phases, that last phase being the outbreak of that rash that we saw. If someone has active rash, you want to avoid skin-to-skin contact because, again, that's how the virus is spread. So avoiding skin-to-skin contact with people with a rash. And the third piece is, of course, washing your hands often and making sure you're practicing good hygiene. Always an important pillar of spreading reducing your risk of infectious disease spread. So prevention, all very important. Getting vaccinated, lowering your risk of MPox during sex or social gatherings, getting tested for STIs, sexually transmitted infections that oftentimes are related to monkeypox, avoiding skin-to-skin contact with people who have that rash, and then washing your hands frequently, practicing good hygiene. So I want to thank you for this time to talk to you all about monkeypox and its relation to HIV and how it relates to our community here in Oakland. Again, monkeypox is a virus that has made a resurgence in the United States, spread by skin-to-skin contact. For folks who have HIV or for folks who may be immunocompromised, they're the ones who are particularly at risk for severe disease. And those 3 really important pillars of preventing the spread and preventing bad things from happening from this virus is getting treatment, if it makes sense for you to do that, talking with your provider about that, getting vaccinated, and taking those prevention efforts, which a big part of is that vaccination piece. So thanks so much for your time, and we look forward to sharing any questions or comments you have and answering them if you have them. Thank you.
I want to thank Dr. Kenji for that excellent overview and bring up a couple of points on access. First off, TPOXX or tecovirimat for the treatment of MPOX. If you are in one of those high-risk categories, your doctor can order tecovirimat for you. But even if you're not and you're interested in being in a clinical trial about tecovirimat for MPox, there is a trial called the STOMP trial. I put the link in the post. You would want to make your medical provider aware of this. So if indeed you are positive for MPox and you're interested in the trial, even if you don't fit into that high risk or severe category, you can be enrolled in that trial to help us learn more. And on the vaccine, commercialization of the Jynneos vaccine began on April 1st, meaning it is going to need to be purchased by medical providers. Several organizations like Roots Community Health still have Jynneos available. So you will want to check in your state or county to see who is carrying the vaccine. There will still be some federal supply for those who can't otherwise access Jynneos, and federal ordering will end in August. So it's kind of going the way of the COVID vaccine and other vaccines, making it that much more important that you have access to a primary care provider. So, like I say every week, if you do not have a primary care provider, please get one. Know how to reach them before you need them. Get your blood pressure checked, your baseline labs checked, like sugar and cholesterol. Establish a relationship with your primary care provider. We all deserve to have one who knows us, who's in our corner. And so put some effort into finding that person if you don't have them already. And as always, remember to eat a balanced diet, incorporate fresh foods, avoid packaged foods, avoid sugary drinks and processed foods, get some regular physical activity. Unless you don't feel well, in that case, please get your rest, manage those stress levels, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.